Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters. I'm your host, Dr. Arti Thangudu, endocrinologist, founder of Complete Medicine and Hey Healthy, and someone who genuinely believes that the best healthcare happens when the right specialists are talking to each other and to you. Today's guest is someone I had the absolute pleasure of meeting in real life, and I've been wanting to get her on the mic ever since. Dr. Alexis Shoope is a board-certified orthopedic physical therapist, certified strength and conditioning specialist, and the founder of Pioneer Physical Therapy and Wellness right here in Houston with me. She has built something truly special, a practice that bridges the gap between rehab and performance with a deep focus on back, hip, and pelvic floor health in active women. Before we dive in, Dr. Alexis, tell our audience a little bit about who you are, how you got here, and what Pioneer is all about.
Awesome. Yeah. Well, thanks for having me. Super excited. If we go back to the basics, I am actually from Indiana and grew up there, but lived in Houston a little bit, kind of back and forth. So I've been back in Houston since 2018. Most of my family's here. So Houston really is home. I went to PT school at Northwestern up in Chicago and then did orthopedic residency down here at Memorial Hermann. And, I didn't go to PT school knowing I was going to run a business or anything like that. And just kind of over time presented itself and just has been like a super fun journey. So to give you a little background of that, I worked at a large hospital system for the first 4 years of my career. And then I started Pioneer kind of initially like the first year as just a side gig and honestly was pretty much all virtual. And I used my personal Instagram at the time to really help people who felt like there was a missing piece of their rehab or kind of that like what you stated, the bridging the gap between rehab and fitness or rehab and performance. So I helped a lot of people who basically did some rehab but felt like, okay, I never fully got back to running or never fully got back to basketball, like recreationally, things like that. And so that's kind of how it started. And then essentially was doing way too much and just kind of felt like, all right, well, I think at some point, we're going to have to take the leap and start. And so, my faith is a huge part of my life. And I just really feel like the Lord was like, okay, now's the time. So I left fully and I've been like full time with Pioneer since February of 2022. So just a little bit over 4 years. And currently our team is 2 admin, 4 PTs, and we're currently hiring for our 5th PT. So it's been super fun. We definitely, right now we're an all-female team. So naturally we work with a lot of females and especially with like the pelvic health side. But I really believe kind of like the best pelvic health PTs are those who have a very strong ortho background because the two are definitely going to talk to each other. It's not like the pelvic floor just lives on an island on its own. So, that's kind of what it's been. And, we're located in central Houston. We have our own space now, just actually expanded about 2 months ago. Our neighbors moved out. So that was a huge blessing for us because they retired. So we've been able to expand the space and everything. So it's been a lot of fun.
That's awesome. First of all, I'm so proud of you for branching out on your own. I think it's hard to do and it's scary, but I don't know. I feel like so many people, women especially, put more faith in their employer than they do in themselves. And I hope some of these conversations encourage people that know, if you're smart, driven, organized, all of those things, you should have faith in yourself that you can figure stuff out. And I didn't realize that we had a Northwestern connection. I went to
I don't know if I
Northwestern
knew that
undergrad.
either. Yeah.
Yeah,
Wow.
so go Cats. That's
That's
awesome. And
awesome.
here I am wearing a purple sweatshirt. So that's awesome. I definitely loved Northwestern. I actually went to journalism school as an undergrad. I did pre-med in journalism at Northwestern.
Wow.
So that's
But you were up in Evansville, right?
Evanston. Yeah.
Evanston, yeah.
Yeah.
So all of the med stuff was downtown. So I've seen, I think I went to the Evanston campus once, which is beautiful. But yeah, we were down right off Michigan Ave.
Yeah, I did some courses at the medical campus too.
Okay.
So I know the the downtown campus is like an amazing location
Yeah.
too. Totally a
Yeah.
different vibe than
Yeah. Totally different.
Evanston.
Yeah.
But really cool. That's awesome. Okay, so in your experience, what did you feel like the traditional delivery of healthcare and physical therapy, what was it missing? Like, what did you see happening to women that you were like, this doesn't seem quite right? And I know you're gonna have a bunch of answers, but
Yeah.
um, what kind of gaps were you seeing?
Unfortunately, there's a lot. But probably the one I saw personally, like even within myself and, feeling like I was a good PT, really wanted to do my job well and like serve the people that were my patients well, was just like the knowledge or the lack of knowledge into the public world. So, Northwestern's a great school, but even then we had maybe like 2 hours of courses around like women's health in particular. And then when I was at my previous job, I was like our back and hip specialist at that location. So about 75% of what I saw was back and hip, which is obviously right by the pelvic floor. And so I would get questions that unfortunately I'd be like, I really don't know. It's not an area I've like studied or really been taught at all. So I'd send them to somebody else. So that was a huge gap of like a lot of PTs. You go to school, like any medical based school, you go to school to be a generalist, right? They have to teach you the key things initially, and then you can additionally like specialize from there. But I feel like it's gotten a lot better, but I feel like when I was graduating in 2018, it just wasn't really talked about. And so I think that in itself was a huge gap. So it was just, even as a female, I couldn't help them in certain things. So I think that as a whole, just like if you go all the way back to school and education level, was a big missing piece, which I do think has improved some. But then I think like just, now with my business, we're fully out of network. We don't take insurance. I think there are unfortunately quite a bit of limitations for those who were using their insurance, and even just the mindset of like, okay, well, some insurances, as an example, may allow 10 PT visits for the entire year. So you could have back pain, let's just say, that just bothers you at work every day. 6 months later, you can be a tragic car accident, and it's not like those would reset. So if you already used 10 for your back previously, so then what we'd see a lot is like, let's say someone was in that same scenario. They had used 6 or 7 previously. They had 3 left. They were in a bad car accident. They would like basically ultimately try to just use those 3 to get better. And it's like, you need way more than that. So I think almost I know that obviously not everyone has the ability to do that, but the mindset that insurance puts people in to be like, oh, well, if that's all I get, that's all I get, when like their ability to maybe go higher or to get even back to baseline wasn't there. So I think just some of the limitations that insurance would bring, and maybe it wasn't even just like where there's an actual visit limit, but let's just say another common thing is, let's say someone was coming again for back pain, and then they just also had ankle pain. A lot of times insurance would only want you to work on one body region at a time. And so you'd have to make sure the back was better before you even looked at the ankle, which makes no sense because there can be like so much more overlap between the two. So then you're actually wasting some time when like you could be improving at the foot and ankle, but because you have to wait to finish the first case, just things like that just didn't always make sense. And then I think probably lastly was just unfortunately the nature of a lot of the larger systems. And I understand fully there's business reasons why they have to do it, but I was seeing it always 2 to 3 people at a time. And so you could be the world's greatest physical therapist, but you're not a robot and you're not AI, so you can't just do everything perfectly at 100% effort for everyone that you're seeing at once. So I think that was hard too. Like there are people where, as much as I'd want, I'm like, oh man, I didn't progress pretty much anything with them today because I'm managing this and I'm managing that. And they were never paired up. So I could have an 80-year-old with an 18-year-old who tore the ACL with a 35-year-old mom all at the same time and like have to try to manage that. So I think those things were just hard because there was a lot of limitations.
Yeah, I mean, I think that there's this idea that I guess maybe the insurance companies have intentionally created, that what your insurance gives you is what you need. And most people choose their clinicians, whether it's a physician or a physical therapist or any sort of healthcare professional, based more on, well, what's covered by my insurance than who is the right person for me. And when we come out and say it, there's just something so intrinsically wrong with that. Um, but it's understandable too, because people pay a lot in insurance premiums. And so the expectation is that their insurance should cover their health care. Unfortunately, we live in a system where that is not true, and it's becoming more and more untrue as time goes on. But I do like that you brought that up because, you know, a lot of people have this idea that if my insurance doesn't cover it, I can't have it. They think that if their insurance isn't accepted at a particular practice, like, they can't even access it, or it would be so expensive to access that it isn't accessible, when in reality, cash pricing for healthcare, even not even just, a visit with a provider, but even labs, imaging, all of those things is often way less expensive than the insurance negotiated rate, and I have a bunch of information on that through my social media and podcast too that we can link to in the show notes. But, like, I think that what I think you hope and I hope is that when people are listening to this, they know that, like, okay, if it's not covered by your insurance, that doesn't mean it's not an option for you to explore. If it doesn't make sense financially, okay, that's fine. But you do deserve to see the possible options that are available for you. And the interesting thing about pelvic floor PT, and I want to ask you so many questions about that, is like people don't even know it's a thing or what it could help. So, would you mind just talking to us about that? Like, what the heck is pelvic floor PT? What are issues that women, I guess, or men, but mostly women, this podcast, the audience is mostly women. So, what are issues that women are dealing with that pelvic floor PT might be really helpful for?
Yeah, and I think it's funny, so my view is super skewed because I'm in that world, and a lot of, like, the people that I'm following on Instagram are in that world too, so it's like, "Oh, man, there's so much more information," but still in the grand scheme across the board, there's so little, or just, like, the understanding. So, really, in general, pelvic floor PT is gonna be PT that's analyzing, things more specifically at the pelvic floor, which usually means that the source of the symptom or pain is the actual pelvic floor. So, in theory, if you go to traditional just orthopedic PT, if we had a better level of education maybe from the start, every PT would be able to think of, like, the system of the pelvic floor, just like they would be able to think of what muscles are in the quad, what innervates the quad. But unfortunately, that piece is just kind of left out. So the pelvic floor world are usually those who went on to learn a little bit more into that specific area. But then I think the way that I explain it, again, having the very strong ortho background that I have, is I had that first, and now basically all I do is, like, put on a pair of glasses that give me the pelvic floor lens I didn't have before. So I'm still gonna be treating the person, looking at everything, 'cause a ton of stuff is gonna impact the pelvic floor. But the additional benefit is I can also do an internal exam if that's needed, and obviously if the client is okay with that. So kind of common things that the most common things, I guess, that you'll see, and as you mentioned, a lot of this can be male as well, which is an even smaller subset that they have no idea that's happening. One of the PTs, not myself, but one of the PTs on my team does treat males, so we actually do have them as clients as well. But kind of the most common things are going to be incontinence, so basically people when they're leaking urine, and that can also be fecal as well. But most commonly, you're going to see people who have that issue with, like, coughing, sneezing, laughing, jumping, running. And then another really, I don't know, maybe a little stigmatized, people believe that only happens once you've had a child. There are tons of women who are having that issue well before they've had children. It's actually, I think the percentage, I wish I knew exactly, but the percentage is either 46 or 56% of female adolescent athletes are leaking when they play their sport. So they have it mostly isolated to their sport. Like if they sneeze or cough, maybe not so much. So yeah, there's just like a lack of awareness there, that it is an issue even in like 14, 15, 16-year-old girls. So you don't have to just have had a baby. But that's probably one of the most number one things that we'll see. And then another is just like pain with sex. So that's something, again, can happen pre or post a baby. And then prolapse or like pelvic heaviness, or like pelvic fatigue is how sometimes people will describe that. So those are probably like the most common. And then just even the basics of, okay, I have had a baby. What can I do during pregnancy? And I think that world is getting better. Women realizing like what they can do instead of just being told essentially that, oh, you shouldn't do anything, or being scared to think that movement in pregnancy is really harmful for you and the baby, which is usually completely the opposite. and just progression back to fitness or whatever. The mom wants to get back to postpartum is a big piece of what we can do as well. And then some other common things would be those who have had, male or female, who have had back or hip pain for a very long time, seen like pretty good, PTs or physicians, and there's still a missing piece of the puzzle. Sometimes it can be that the pelvic floor was never taken into account. And so something there could be impacting that just because of the proximity too. So there's a lot of other things, right? There can be nerve-related issues. There can be obviously different types of surgeries that happen there, but kind of on a broader scheme, I'd say those are the things that are going to be really common in the pelvic floor world.
So it's interesting because they're all things that nobody wants to talk about.
Yeah.
And they're all things that we are undertrained on in medicine. So let's say someone goes to their PCP with these issues, the PCP might not even be aware that there's a pelvic floor PT option that can help. So I think there's multiple layers of why people aren't getting the care that they need and that can be really helpful. So interestingly, just a couple of weeks ago, I had a patient who's postpartum who was experiencing a lot of pelvic heaviness after activity. She's like 12 weeks postpartum now. And I was like, there are some things that will resolve themselves after you have a baby with time, but if it's bothersome to you, I would consider going to a pelvic floor PT. And I was like so grateful that I even had that in my toolkit. And I kid you not, like she came back to see me a couple weeks later and she's like, you know what? I hesitated, but I ended up doing the pelvic floor PT and my symptoms are gone, like completely resolved in just a couple of weeks. And, I don't know, maybe she's further postpartum that probably has a part to do with it. But I just was like, okay, this is something that we kind of need to be like screaming from the rooftops for women, right? Like that this is an option. Obviously, it's not going to fix every single problem, but there's a lot of issues that women deal with in the pelvic region or around it because of childbirth, but just also because we're women that I think need to be explored. And I'll tell you another story. When I was pregnant with my son, I was carrying around my 2-year-old daughter all the time. And I had been a long distance runner my whole life. And I could not run because I'd have such severe glute pain in my right glute. And I was like, okay, well, this will just end when I deliver him. And it didn't. And we're so untrained in medicine, at least when I was going through it, on physical therapy, that physical therapy did not even cross my mind. I look back and I'm like, that should have been the first thing I thought about while I was pregnant. Anyway, so I went this whole roundabout way, finally found myself in a physical therapist's office, and I kid you not, he changed my life. Like, within 3 months, I was not only running again, but my pace was faster than when I was in high school. And so it was like completely life-changing. And so I do think that like PTs aren't referred to enough for people who are functional. I feel like it's reserved for people who are after a really bad car accident or have had a major surgery or have had these big traumatic events. But I think for the tiny aches and pains that take people out of the gym or out of their sport that really like have cumulative effect in health over time are kind of being missed and ignored. So I love that you work with those people because we want the functional people to stay functional.
Well, and that's like a big thing too, is there's a lot of, so the cash-based world is still very small in Houston compared to other areas, but probably 90% of
because
our
we have
clients,
such big hospital systems here that are very powerful. But
and it just seems scarier. But there's so many people here that like, there could be so many more businesses like mine and they would still do well,
There's so many people.
Yeah, but probably 90% of the people that come to us are just like direct access. They have referred themselves. And so what you see a lot in some of these smaller clinics, whether they're cash-based or like a private practice, but it's still insurance-based, is they advertise to athletes. And so the person who is still a super active adult who is running and lifting regularly, sometimes they don't put themselves in that category. So they don't really feel like they have a place to go. So that's been another thing is like we capture those people who it's like, oh no, we work with high-level individuals. They don't have to be competing left and right. You don't have to be having a powerlifting competition once a month and then playing recreational basketball 24/7, but they want to do those things or they want to do it with their kids or whatever. And so, yeah, very much like what you said is it's still a huge problem of people even realizing that PT can be an option, and that it doesn't have to be when you are completely taken out of your entire life, basically. So
Yeah.
it's been fun to work with those people, but it still is something that's, I think, a confusing piece for people.
I have a question and a comment. So, one, I have found that too, that people who refer to us because we're out of network as well are mostly people who are self-referred or, they were referred by a patient who had been seeing us, who's their friend or something like that. But it's really hard, I think, for physicians or clinicians in the traditional insurance space to refer to a cash-based practice. I wish we could break down that barrier because we refer
Yeah.
opposite all the time.
Yeah.
We
Yeah.
refer to
So do we.
insurance-based
Yeah.
practices all the time. But I think there is a gap in understanding of like why people are going out of network. And it's more about being able to provide the care that you feel like the patients deserve, not being restricted. It really has very little to do with making a whole lot more. You can or you might not. It really is variable and you're taking a huge risk and basically putting everything on the line because you believe so deeply in the care that you are capable of giving your patients, but limited by in the traditional setting. I think that that's a real misconception about doctors who practice cash. And I understand there's a lot of reasons for that. But my question for you is you talked a lot about like symptoms that people might benefit from pelvic floor PT, but what are some diagnoses that you feel that you're making often?
Yeah, so I think probably for our population who we see, incontinence is probably the number one thing that we see. So whether that's stress or urge or mixed, that's probably the number one thing that we see. Another thing, I guess I didn't say this earlier, but another big one can be like figuring out why they're having constipation. That's another thing that people don't realize that pelvic floor therapy can help with. And then again, the pain with sex, or I always pronounce this wrong, dyspareunia is another
Yeah.
super common one. So figuring out why a lot of it is what I would say is different of the pelvic floor world and like the orthopedic world. So in the orthopedic world, if someone comes in with back pain, like back pain in itself is not a diagnosis. That's just telling you where the issue is. But then our role is to figure out, okay, what's the diagnosis? Why is this happening? Is it a facet joint? Is it discogenic pain that's more localized to the back? Is it um, anything else that could be specific to that region? Whereas I feel like what's common in the pelvic floor world is you almost kind of have a diagnosis, but then you're figuring out more of like why it's happening. So let's say, as an example of stress incontinence, someone is specifically peeing when they run. Is that happening? Then our role becomes more of the why it's happening because we know it's happening, right? They have the symptom of it, but why is it happening? So is it because just like any other muscle, the pelvic floor muscles are fatiguing? Is it because there is so much tightness that the increase in pressure of running is too much? Is it a pressure management issue where it has to do with how they breathe when they run or positioning when they run? And so in the pelvic floor, again, with incontinence or leaking, you don't leak anywhere else. And so that's why sometimes people, that's a hard thing to talk about. But it's usually like, is there something that's in a certain position that's adding more pressure that's causing a leak to happen because of just the pressure management? Or is it because there's actual weakness and that the sphincter itself isn't strong enough to close or the muscles around it aren't strong enough to assist that? So I feel like, at least from what I've seen, is sometimes people almost come in with a diagnosis in the sense that that's the name of it is going to be incontinence. We already know that. So then we're diving deeper. Okay, it's stress incontinence. Okay, but why? And then looking through those variables because we could say all the things, but what's their main reason and how do we decide what we work on first? So that's probably how I would describe it. That's a little different than orthopedically, where it's like we have the painful region, and now we need to figure out an actual like pain generator. What is the actual source of pain?
Yeah, and I think this is really interesting because there's a lot of interest in like root cause
Mhm.
medicine right now. And I think that for most things, physicians try to find the root cause. Like, it's not like we just want to put a Band-Aid over a symptom. And so even with like hypertension, okay, why is the patient having hypertension? Is it a vascular issue or is it a endocrine issue or something? We are thinking about those things. And there's this idea that we're not. But I do think when it comes to like MSK stuff, most general practitioners have a huge limitation in their knowledge of the musculoskeletal system, right? Like, I don't think that most general practitioners have the depth of knowledge that a physical therapist does, like you, to go further and get that root cause diagnosis, you know? And so I think that's where physical therapists can really add to your primary care doctors or your general practitioner's assessment and treatment plan in a way that they couldn't do on their own because maybe their depth of knowledge is only how to treat the pain or giving like basic stretches that they Googled and printed online, you know? So I think that's such a huge additive value. Are there like, if you could pick like three things that are the most common causes of stress incontinence, pelvic pain, and pain with um, intercourse, are there things that you're just seeing over and over again that maybe women should be thinking about when they're having these issues?
Yeah, I think so. This is going to be super simplified, but there's kind of more behind it. Unfortunately, what we see is a lot of it can be due to like just a ton of tightness in the pelvic floor, which usually then you figure out why. So is the tightness happening because of the fact that there unfortunately has been trauma previously? So now that could be through childbirth or that could be through other things. That area, your body, your brain and your nervous system are going to regulate everything that happens everywhere else. So is it almost wanting to close off and keep that area limited in movement and mobility? Is the tightness happening just because someone is really internalizing a lot of their stress or they're constantly at a high state of stress? And that can be seen with, common themes of that are going to be like jaw clenching as well, or just a ton of tension up in their upper traps, those kinds of things. They don't always have to go together, but we see those trends. And then unfortunately, I think just across the board for women, it's getting better, but as a whole, women still don't strength train anywhere near the level that they need to be. And so truly, like your pelvic floor, when you compare it to the muscles around it, like the quads and the glutes, like it's not very strong, like comparatively. And it's not supposed to be. It's not supposed to take on all the load there. But if women as a whole just aren't strength training. So I can give like a little story of myself. So when I got into this world, the pelvic floor was like completely foreign to me. I literally had no idea how to activate it. So like, classic Kegel that everyone knows about that all of pelvic floor PT is simplified down to, I literally could not do it. So if there's a scale based on how we rate muscles, 0 means you physically can't, like there's nerve damage. I didn't have that, but I had like a 1 out of a 5 scale. So my ability to coordinate it from my brain down to those muscles was very, very, very minimal. So I spent a lot of time trying to just learn how to do that, not because I needed it, because I was having no symptoms, but because to teach it and all that. But the reason, at least is my theory, why I had no symptoms, had no problems, was because of how much strength training I did. I've always lifted, and I've gotten like more into it probably in the last 5 to 6 years. But because I lifted so much, so often, single leg work, all the things, I never experienced leaking. So I could sneeze, cough, laugh, jump, run, and have no issues. But I really believe it's because all the rest of the system was doing what it was supposed to do. So I would say probably those things, like just kind of overall tightness, whether that's due to previous trauma or just like high stress, unfortunately, and your body will internalize that. And then just the lack of strength training in general, I think is a big piece of it too.
Okay. And then, okay, so let's say we are dealing with tightness. Are there specific things that pelvic floor PTs or that you do in your clinic to help people with that?
Yeah, probably number one, I would say, is going to be just awareness. So there's some aspects of that people can control, right? So the aspects of that is like, how do you even manage your stress? Are you constantly clenching? Are you constantly squeezing your glutes where things are tense down there? And so half of it is awareness, right? People don't even realize that that's a thing, then they can't necessarily do anything about it. And then from there, it's depending on the individual and why it's happening. There's lots of strategies that we can use. I think a lot of people, when they think of, again, pelvic floor PT, they think of kegels and they think of breathing, and that's basically it. Those things can be a piece of the puzzle. If someone has a lot of tightness, we're not going to give them kegels, because basically it'd be like if you take a bicep contraction and normally, you want to be able to move through the entire range of motion. But if you're tight, if I tell you to just do a bunch of kegels, this is all you're going to get. We need to lengthen to allow the muscle to be as strong as possible, to give it its optimal muscle length tension relationship before we would strengthen. And honestly, there's lots of things you can do to strengthen the pelvic floor without it just being like a contraction of the pelvic floor itself. So anyway, the reason that breathing can be a big piece for that is, one, it helps to like activate your parasympathetic system, period. And like some people, it's just really beneficial for you to take a few minutes to like take large inhales, large exhales. But then the other thing is, every time you do that, the pelvic floor naturally is going to lengthen because it mirrors the diaphragm, and then it will kind of go back to its resting state. And in breathing, we're not having it actually contract unless someone's cueing you for that purposely. So there are a lot of things like that. A very classic, like let's say someone is having pain with sex, and it's let's just say they're postpartum, and so they did have a child recently. It was vaginally, so their body, your pelvic floor stretches like 200 to 300 times its normal resting state when you give birth, and so your body is naturally going to tighten up there afterwards. And obviously, if there's tearing, that can be part of that too. But unfortunately, sometimes people believe it's just going to be like that forever. But there's a lot of things we can do. So something as basic as like a few breathing exercises and then resting in child's pose beforehand. Like, yes, it's planned rehab before, but it is something that can help. So those are, again, like kind of some basic things. And then part of it too is like our pelvic floor often can just rest in a shortened position a lot of the day. So like if, as I'm sitting here with my legs crossed, that's not a bad thing. But if we're constantly doing that, and like the opposite of that would be doing something like an RDL or a hip hinge that's going to lengthen the pelvic floor and get it out of just a shortened position that a lot of times we just are in most of the day. Just if we were to keep our arms like this all day, eventually it'd be really hard to straighten it out if that's how we always lived. So those are all like little things that can be helpful, but I really do think like a big piece of the puzzle is awareness, especially if there's certain things that the individual is doing that could be controlled in a way.
Now I'm breathing deeply and uncross my legs.
Yeah.
Okay, so now how about women in midlife, like with the perimenopause, menopause transition? We all know that's a very hot topic. Are there certain issues that you're seeing a lot in that space, and things that are benefiting women who are dealing with those issues?
Yeah, so probably maybe like a year and a half ago, that was just something I wanted to learn a lot more about. And it's still an area that I'm still like new into learning about. Because it is becoming a topic that a lot of them are asking about. But what's super interesting is there's a ton of symptoms that can happen around that time period. But, the classic things are you lose your period and you get night sweats. Like those are the things that people talk about, but there's so much more. But one of the biggest things is we can see a lot of just typical musculoskeletal pains be due to going through or being perimenopausal. So that's been something that's super interesting and been helpful to guide of like if we're working with a client in that age range who is postmenopausal at this point, or who maybe their period is a little bit less consistent at this point. Even before that, you can have a lot of hormonal changes. But estrogen is just so helpful for a lot of aches, specifically in the joints. So if I have a female who it seems like we've done everything under the sun, they responded decently, but not 100%. Before I would have probably just been like, okay, what am I doing wrong? Or are they not being consistent? But now there can be a systemic thing to consider that I feel like I didn't consider before. So I actually would say one of the biggest things around that time frame is just additional joint pain that like orthopedic PTs are going to see a ton. And then probably two others that are going to be like in our world. There's others, but maybe the top three is going to be the incontinence is going to be a big piece around that time as well, potentially. And then going to the bathroom at night. That's when you start to see women have that increase. And so how can we teach them habits that can help with that? Because I think a lot of women believe like, oh, once I start aging, like that's just the new norm. And that even in pregnancy, technically, you actually shouldn't have an increase overnight, which is most women would never believe. So a lot of it can be, again, can be trained, and actually is a lot of like brain training and habit training. So some of those clients we do exercise, but maybe not as much. And it's actually more of like, okay, take a log of this, what things are around this time, how can we change it? But I think, yeah, it's still an area I'm definitely learning into, but some things I probably just would have seen and never have taken into account their age, or never would have asked specific questions about their period. And then wouldn't have realized that there could be more of a systemic effect. And like, when do I need to refer to somebody else for that?
And have you seen patients improve with estrogen therapy?
Yeah, so I would say this is still a pretty small percentage of people that we've seen, but I have seen it in actually some family members, and then as well as some clients where, and maybe they're not to 100%, but they got to, let's say, 70 or 75 with us, and then we've connected them, and they've had obviously worked with somebody who can specifically help with that, and now they're closer to 85% or 90%. So a lot of times those people are still seeing us because obviously your tissues still want to be trained and all of that, but then they're maybe having something else added as well that makes a difference for them.
Yeah, that's amazing. I feel like I've seen that too. Um, and I think this is really important because, like, incontinence, pain with intercourse, pelvic heaviness, and just discomfort are all things that are so quality of life limiting and also, like, can seep or do seep into every other aspect of your life, your relationships, your self confidence, your ability to do your sport or do your exercise. And if you can't do those, then you end up with, diabetes or insulin resistance or things like that that nobody wants to have. So I hope that people listening to this just take away that there are things that we can start intervening on early if you get the right therapist. And you don't have to just live with it or just deal with it or allow it to get worse. There are options. So as we wrap up, I just wanted to know if there are if you could just spitfire, like, the top 3 things that you wish women would start doing for their pelvic floor health, like, at home. If they could just do 3 things every day, to support their pelvic floor, what would they be?
That's a great question. Okay, so the first one is more of a, you can tell if it counts in 3 or not. My number one thing would be stop just doing kegels to solve all your problems. So, like, that's the biggest misconception. And sometimes that can make things worse. Or like, people have been told, every time you go to a stoplight, just do like 10 of them. And it's not going to get you anywhere really, unless you are someone like me, where my activation there was just basically not there, where I actually had to do exactly that. So I think that's probably one thing, is it's way too simplified down to that. And unfortunately, then people think they're helping themselves, and they're probably not going to make too much of a difference with that. And then I would say, in general, like, find a way to manage stress and find things that help you to relax, because that in general is unfortunately a big foundation for a lot of the issues that we see. And then I would say absolutely strength training. So specifically the things that, I mean, whole body for sure, but the things that we see that are going to be very, very helpful specific to the pelvic floor, if I only picked 2 things, would probably be your adductors and your glutes. So because they work as synergists and work so closely with the pelvic floor, I think those would be huge. And that means not just in what we would call sagittal plane, so just like up and down, doing rotational things, doing things side to side, not just an up and down plane. So I think those would probably be my top 3. Like, truly, again, strength training, there's so many layers to it, so many levels to it, and it's a huge piece of what we do. And basically every Pioneer has additional training in that aspect of things, instead of just like, okay, we're going to do 3 sets of 10 of this banded walk. That's good to start, not going to make the game changer for someone who is not brand new to things, or is mostly, we use it as like a warm up. But yeah, I think just in general, that's a huge piece that could, if done well, and sometimes people need guidance in that, can make a big, big difference into a lot of the problems we see.
What's your favorite glute exercise?
Absolute favorite. So probably hip thrust are one of my personal favorites, selfishly, because it's one of those that you can go heavy pretty quickly, and so it's just rewarding. But I think
Mhm.
from like a rehab standpoint, maybe like more of a single leg hip thrust, or a step up, and like specifically a step up where you position your body in a way that's not going to be only quad dominant, that you kick in your glutes a little bit more. So probably from a rehab standpoint, like single leg hip thrusts or step ups, and then personally just heavier hip thrusts are fun.
Oh, I thought you were going to say clamshells.
Oh, no. That's another big misconception that PTs give so much, and it's the glute activation is actually pretty poor in that. So
Oh,
that's another thing.
see, that's why we all need your help.
Yeah. That is probably bridges and clamshells are, like, the 2 that are handed out for, like, everything, and some people do need to start there again. That's okay, but the problem becomes this would be, like, another issue just in general with, like, traditional model. If people stay there forever, that's probably not hard enough for them over time.
That's really
But
good
yeah.
advice, which is why we all need, like,
Yeah.
personalized plans for us.
Yeah.
Um, okay, so thank you so much for sharing your advice and your
Yeah.
knowledge with us. Where can people find you to see you as a patient or online?
Yeah, so I'm not as active on personal Instagram anymore just because the business is doing so well, which is a huge thing, but it takes me away from there. So I do have, a personal page. It's just dr.alexis.shoope that I still use, just nowhere near like I used to. And then we do have a business page that's just pioneer.pt. And then the second E in pioneer is actually a 3, which always throws people off. And then just our website, which is pioneerpt.com. Basically on there's 2 ways to reach out to us. You can fill out what's called a contact request form, which basically we will receive and call you as soon as we get that, or text you as soon as we get that. And then the other option is on that same contact page, you can actually set up a day and time that works for you to receive a call. All of our clients start with like a free 10 to 15 minute conversation with us just to make sure obviously we're the right fit for them, they're the right fit for us, and then kind of talk through the process. But yeah, all of those would be great ways to connect with me or my team as well.
Thank you so much for spending some time with me today. I definitely learned a lot, and I hope our audience did too. And my name's Arti Thangudu, and you can find me at essaycomplete.com or my Instagram at Dr. Arti Thangudu.